Bien, ahora es el momento de las conferencias inaugurales. Tenemos 2 conferencias y 2 conferenciantes de altísimo nivel. Y para mí es un placer presentar al doctor Steven Grinspoon, con el que he tenido conocimiento y he aprendido desde una época muy larga. Steven, you can come to the podium. Steven ha trabajado desde un área que no es estrictamente el VIH. Él es endocrinólogo en el campo de VIH, como cantidad de otros especialistas que inicialmente no se formaron o no trabajaban en VIH y han contribuido desde su puesto, desde su posición, desde su temática de investigación al campo del VIH. Steven Grinspoon es profesor de medicina en Harvard Medical School. Es también jefe de la división de metabolismo en el Massachusetts General Hospital y también es jefe de neuroendocrinología y metabolismo en el mismo hospital. Él ha investigado sobre lipodistrofia con los tratamientos antiguos, antirretrovirales, que sabéis que tenían este problema, y fue un ponente asiduo del International Workshop on Lipodystrophy and Adverse Drug Reactions, que era un congreso específico dedicado a este tema. Él ha hecho descubrimientos seminales en el campo del tratamiento con algunos fármacos dirigidos originalmente a lipodistrofia y más tarde que han tenido repercusión en la enfermedad grasa hepática y otros aspectos también diferentes. Y ahora está con nosotros porque es el líder del estudio internacional REPRIEVE, que es un estudio probablemente conocido de todos. Es el ensayo clínico más grande con pacientes seropositivos, con personas con VIH. Tiene más de 7.000 participantes y es un ensayo clínico que ha avanzado, no se ha detenido, por tanto tiene visos de seguridad para mantenerse y si efectivamente la hipótesis se demuestra, pues cambiará el sentido y el paradigma del tratamiento en las personas con VIH. Steven, whenever you want, thank you for coming here.
Thank you very much, and thank you for that very kind introduction. I must admit I didn't understand all of it, but I thank you, and thank you for being such a good friend over the years, and thank you to all the organizers of this. I really appreciate the opportunity to speak to you today. So I'll be talking, as Esteban mentioned, about cardiovascular disease and HIV and the lessons that we've learned from REPRIEVE to date. These are my disclosures. In terms of relevance, I don't need to tell this audience, but over 35 million people are living with HIV today. And even as the rates of death and mortality related to HIV have decreased with the use of more potent antiretroviral therapy, rates of cardiovascular disease, including MI, stroke, and sudden cardiac death, remain increased among HIV patients and are a leading cause of morbidity and mortality. Put in another way, let's look at the life expectancy and comorbidity gaps which persist among patients with HIV. On the top 2 set of lines, you can see total years of life expectancy remaining at age 21. You can see the gap has closed somewhat, but not entirely. There's a 9-year gap between HIV positive and HIV negative participants or people in this study. But if you look at the comorbidity-free years, there's a significantly greater gap of 15 years in terms of that, and it has not lessened as much as total life expectancy. So patients are living longer, but they're living with significant comorbidities that have contributed to morbidity overall in HIV disease. So let's start with a little bit of a background on cardiovascular disease in people with HIV. And this risk is increased beyond that predicted by traditional risk factors. And you can see here on the slide a series of epidemiological studies which show the hazard ratio or effect size of myocardial infarction in HIV-infected patients versus non-HIV-infected patients. And the blue line is a line of unity. And you can see all the studies, and these are major studies, including a global meta-analysis by Shah et al., showing about an 80 to 100% increase in cardiovascular disease in HIV-infected patients. One of the more famous ones was the VAX cohort study, where the hazard ratio was 1.48, or almost 50% higher in HIV versus non-HIV, adjusting for the Framingham risk score and comorbidities. So that's pretty interesting and pretty incredible when you think about it, even adjusting for Framingham risk score. And that was also illustrated in one of our earlier studies, in which we looked and showed that the risk of cardiovascular disease was 75% increased in HIV-infected patients versus non-HIV. And yes, the HIV-infected patients in this particular study had more hypertension, had more diabetes, and had more dyslipidemia. That's really important. But that troika of comorbidities only accounted for 25% of the excess of cardiovascular disease in this population. So it's very important, but it doesn't look at all the causes, and there are other causes, probably inflammation, that is contributing, which I'll get into shortly, and which Dr. Soretti will also talk about in a moment. Now, there's a significant progress that's been made recently in terms of understanding the cardiovascular disease in HIV. Recent studies in this population, in HIV patients without known clinical cardiovascular disease, demonstrate that atherosclerotic plaques are inflamed, non-calcified, high-risk morphology features, so they're vulnerable, and they're associated with immune activation markers. This is a very, very important pattern that we see in these patients. And in fact, in the general population, inflamed, non-calcified, and high-risk morphology plaque is more prone to rupture. And myocardial infarction results from rupture of vulnerable plaque in 75% of cases. So in fact, the HIV population has the very phenotype of vulnerable disease that is so critical in the general population, in which we need to worry about, and which we need to focus our therapeutic targets at. So we did one of the original studies looking to prove that there was increased inflammation in HIV-infected patients. And in this particular study, we used FDG PET, and we compared an HIV cohort, a Framingham risk match cohort, and a third cohort of non-HIV patients with known cardiovascular disease. FDG PET is a congener of glucose that gets trapped in the glycolytic cycle, and you can use it to image inflammation and metabolic activity. And in that study, we showed that the aortic target to background ratio, or the aortic inflammation compared to the background, was significantly higher than Framingham risk match controls, and as high and even slightly higher than in patients in the general population with known cardiovascular disease. And you can see the intensity of the PET uptake in these patients, HIV versus control. So this is a direct demonstration of increased aortic inflammation in this population. We wanted to also look at the particular characteristics of high-risk morphology plaque in this population. And two key characteristics make up vulnerable plaque. One is low attenuation, so the plaque is not calcified. Now, I know we talk a lot about a calcium score as a high risk. That's true because it's associated with smoking and other things, but those are plaques that have actually kind of sealed over and calcified. The riskier plaque actually is the non-calcified plaque, and it's actually positively remodeled and eccentric to the core of the lumen of the artery. And in this particular study, we looked at patients with at least one positively remodeled plaque or at least one low attenuation plaque. These are high-risk features, and we showed that the rates of these features were significantly higher than the non-HIV population in which we studied, and they were Framingham risk match. Again, more demonstration of a particular phenotype of cardiovascular disease in this population, which could be contributing to the higher risk of overall cardiovascular disease. In the general population, there are significant clinical implications of high-risk morphology plaque. And you can see that patients with two-feature positive plaque have a much lower cumulative event-free course than patients with these plaques. So this is really significant, and this is suggesting that we have a special phenotype of inflamed vulnerable plaque which may be contributing to cardiovascular disease. And together this has formed part of a new paradigm of atherogenesis in HIV, which I'm going to talk more about in a moment. And that is that in addition to the traditional risks of dyslipidemia and hypertension and all these other things, which we absolutely need to focus on, and they should be part of our prevention, we need to think about this other paradigm where persistent viral replication, microbial translocation leads to T-cell activation and monocyte activation, contributing to high-risk plaque and inflammation. And that's the particular thing we need to target along with traditional risk in this population. And that leads for current challenges in preventing and treating cardiovascular disease and HIV. We first need to identify patients with the disease, and I'll show you data in a minute that our current risk identification strategies are not adequate for the job. We need to understand the optimal timing and the use of antiretroviral therapy to maximize effects on immune function and minimize metabolic effects. We need to develop a safe and effective strategy for primary prevention, especially for those who are not identified by current algorithms, but who have substantial increase for future events and have substantial subclinical disease. And we need to develop an intervention that both addresses traditional and immune-related risk factors. That's a tall task to have in one particular therapeutic. Now, what about the question of whether whether ART itself does the job? Can you give ART to HIV patients and expect it to lower the inflammation enough and other factors to prevent cardiovascular disease? Well, it's true that the START and SMART studies suggested that early treatment reduced cardiovascular disease, but we see that when you look deeper with more detailed phenotyping, that immune activation parameters improve with antiretroviral therapy, but they do not normalize, okay? And there is persistent inflammation in HIV patients who have no apparent clinical viral load, who have a very good T-cell count. They still have significant persistent inflammation. And you can see here in this particular study, which we published in JAMA Cardiology, that there is a significant reduction in activated CD4 T cells with ART, but it's much higher than a healthy control population, and the same pattern exists for other cell populations. So that's an important thing to think about when you think about preventing cardiovascular disease in this population. We also showed in that study that there were discordant effects of antiretroviral therapy on immune function and arterial inflammation. So this is a patient before and after antiretroviral therapy, and you could see that the person had significantly enlarged lymph nodes as an ART-naive patient, and with antiretroviral therapy, they shrunk right down, and the immune function improved, but though not back to normal, as I mentioned. In contrast, in this particular study published in JAMA, we saw no significant diminution in the aortic inflammation, at least over this 6-month period. It seemed to be stubbornly persistent, and persisting even in the context of improved overall immune function in this patient population. Taken together, these data have suggested to us that there is a need for a large randomized clinical trial to inform clinical practice. HIV patients with low traditional risk scores are at increased risk for cardiovascular disease with subclinical plaque and inflammation. All the data I showed you before were in patients with, in fact, very low traditional Framingham risk scores. ART alone is not enough to prevent cardiovascular disease in people with HIV. I'm going to talk further about statins in a moment, but they may prevent cardiovascular disease, importantly, through traditional risk factors, effects on traditional risk factors, including LDL and inflammatory indices. But however, furthermore, they are well tolerated to date in small studies, but there are no data from large clinical randomized controls trials in HIV investigating their tolerability, critically their adverse effects and efficacy. And if you look at consider the biology of plaque development in anyone, you have multiple factors which contribute to it. And this includes uptake of lipid, modulation of lipid, inflammation that leads to the necrotic core, thrombosis, ultimately with vulnerable plaque, and thrombosis of that core, and angiogenesis. And statins actually have unique properties to affect many of these particular pathways. They clearly lower LDL, they affect lipid modulation and decrease the uptake of LDL. They improve oxidized LDL and decrease its inflammation. They actually may also improve thrombosis through affecting tissue factor on activated monocytes. So they clearly are an interesting molecule that both have effects on traditional and non-traditional risk factors. We know a lot about what they do in patients with HIV. We know that they lower LDL similarly to patients without HIV by about 26 to 30%, so the LDL lowering is equivalent. But interestingly, they have effects on key factors. This is one particular study by Grace McComsey, and they looked at statin therapy, and this statin therapy significantly reduced soluble CD14 on the left, atypical monocytes in the middle, activated CD4 T cells on the right. So that was really important observation and formed the basis of REPRIEVE in part. I'd then like to focus on another study which helped to form the basis of REPRIEVE, and this is the so-called Jupiter study. This study is a little bit like REPRIEVE, except these are non-HIV patients, but these were patients in the Jupiter study who did not have known cardiovascular disease, but had low LDL and an increased CRP. So they had normal lipids, but some surrogate marker of inflammation. And this study was a tremendous success. In this study, Paul Ridker and colleagues used rosuvastatin, and they showed a significant reduction in the event rate. Importantly, and I wanted to dig into the weeds just for a moment for you to explain something very important to you, which was that the LDL was reduced 47 milligrams per deciliter in this study. And by the CTCC meta-analysis that should have published in The Lancet a couple of years ago, that should have resulted in a hazard ratio of 0.73. Because all the statin studies are basically linear with respect to reduction in hazard rates in LDL. This one was off the curve. And the hazard ratio expected to be 0.73 was actually 0.56, much greater than expected based on LDL lowering alone. And it was thought that this was really due to the reduction in inflammation in this particular study, a principle that you'll see will come into play as we plan for REPRIEVE. Now, in terms of using the current algorithms to predict who should go on a statin therapy, this is a study we published when the new guidelines came out in 2014, the so-called ACC-AHA guidelines. And you can see on the left here, these are patients with coronary plaque with one or two of those high-risk features that I just talked about, okay? So even using the newer guidelines, the 2013 ACC-AHA pool cohort risk, only 25% of patients with high-risk features would be called for a statin, okay? So we're grossly misidentifying patients in our population who we think are fine. They have good viral load, they have good CD4, their LDL is okay, but they really may have high-risk plaque, and they probably are, have a significantly higher risk than background population to go on to a future event, and we're not identifying them with these algorithms. Now, I'm going to talk more about statins, but people always ask me, are they safe? Are they safe in HIV? REPRIEVE will tell us the answer to that, but studies published to date, one by Silverberg in the Annals of Internal Medicine, showed very low absolute rates of grade 3 or 4 adverse effects on liver and muscle, and no adverse effects on immune function. And then we published in the Lancet HIV a few years ago a smaller study looking at atorvastatin, but really carefully honing in on coronary plaque. And in this particular study, we showed very nice effects to reduce the non-calcified plaque volume, seen here. Nice reduction in LDL as expected, but also a very important reduction in Lp(PLA2), which is a marker of arterial inflammation. And this is just one example, but you can see here a classic high-risk plaque. It's non-calcified, low attenuation, eccentric to the lumen of the coronary, and it just basically really shrunk down very nicely with statin therapy. So that's what we're hoping to accomplish with REPRIEVE. Now, the newer statins do not increase glucose or interact with protease inhibitors. And the newest one, of course, is pitavastatin, the one in which we're using in REPRIEVE. It has a very nice effect to lower LDL. It's metabolized by glucuronidation, so it's minimally metabolized by CYP3A. There are no known interactions with antiretroviral therapy. There are no dose limitations. And it's included in the 2013 ACC-AHA guidelines as a recommended moderate dose statin. And in fact, when you compare it head-to-head with other statins like pravastatin, it lowers key markers such as LP-PLA2 and soluble CD14 to a much greater extent than even other statins. So this is significant in part of our thinking about REPRIEVE. In addition to lowering or potentially preventing cardiovascular disease, statins may have effects on other comorbidities in HIV patients. And we'll answer that officially in REPRIEVE, but data to date suggests that statins may delay fibrosis progression among those with liver disease. And interestingly, they might improve, they show modest improvement in creatinine clearance. There's a possible decrease in risk of cancers. And in one study, there was a reduced overall mortality among HIV, though it was a non-randomized study. So all this background has led us to REPRIEVE, which is the randomized trial to prevent vascular events in HIV. REPRIEVE is a landmark trial, and it has been hard to run. But I think it's going to generate significant amount of data for years to come. We have recruited over 7,700 participants from over 100 sites in 12 countries. I might point out, oh, it's on the next slide, Spain has contributed significantly. We have a significant number of sites here in Spain, and we thank the investigators in this room probably for your participation. It's an events-driven trial, which means we need to accumulate a certain number of events to have enough power to robustly be able to determine whether we can prevent events. And we are now happily at 75% of the number of events that are required. The mean duration of a participant so far has been about 5 years, a little bit less in the Spanish sites. And proudly, we've published 29 papers and 14 more in progress. And our retention rate, despite the trial being now going on for 5 years, average mean duration, is still less than our anticipated, less than 5 per 100 person years. These are the countries and regions that are represented in REPRIEVE, and as I mentioned, there's a little dot over here for Spain and our European representation. But we have patients in North America, South America, Haiti, Peru, Thailand, India, Sub-Saharan Africa, all over the world. And we have a number of GBD regions. I want to thank the AIDS Clinical Trial Group, which has been our key partner in this, but we've also collaborated with NEAT-ID here, the Canadian HIV Trials Network, and we have some non-ACTG REPRIEVE sites. The rationale and design for this trial, I don't have time to go into here, but I kind of gave you the background of it. The key points were in my preamble here. It's all listed here in the American Heart Journal, where we listed our design and all the statistical considerations. Suffice it to say, our study population is shown here. Documented HIV infection on ART, so every patient in REPRIEVE is on ART. CD4 more than 100, age more than 40 but less than 75, no known atherosclerotic cardiovascular disease, and a 10-year risk score which is only mild to moderately and minimally to moderately increased. So we're targeting a group of patients that would not be targeted otherwise for statin therapy. So we have achieved equipoise in that. We are excluding current use of statins, gemfibrozol, PCSK9 inhibitors, or known decompensated cirrhosis. So the main objective is to determine the effects of a statin strategy as a primary prevention strategy for major adverse cardiovascular events. I'll go through them in a minute. The secondary objectives are to look at each individual component and, critically, all-cause mortality. Whether baseline risk factors, including sex, which is a really important consideration, and time-updated HIV-specific immunological risk factors are predictive of MACE and statin effects on MACE. We're going to look at the incidence of serious non-CVD events, AIDS events, and we have a number of those in the trial. We're going to look at the effects of statin strategy on those. And of course, we're going to look at safety, including on pre-specified safety endpoints of diabetes mellitus, liver, and kidney disease. This is the study schema. You can see here that patients were randomized in a 1-to-1 fashion. MACE is cardiovascular death, MI, unstable angina, stroke or TIA, arterial revascularization or peripheral arterial disease. But within the overall study, we have an 800-person sub-study called our mechanistic sub-study, in which we are looking at coronary angiography before and 2 years after statin therapy. And in this study, we're also deeply phenotyping patients with flow cytometry and all sorts of biomarkers. We're going to look at the effects on high-risk coronary plaque, on immune function, activated T cells and monocytes, monocyte activation, innate immune activation, arterial inflammation, and the relationship of the change in LDL to immune function, arterial inflammation, and plaque. I want to show you the baseline characteristics of REPRIEVE very briefly. First of all, we're very proud to say that we have a significant percentage of women in this study, 31%, which is pretty good for a large HIV trial. The median ASCVD risk score is only 5 overall. It's 5.4 in men, but 1.9 in women. Don't let that change your thinking, though. We've shown, and others have shown, that women are, in fact, at higher risk relative to non-HIV infected women than men to men are. So women are a really important subset of this study, and it's going to be quite interesting because even with a very low predicted risk, we're starting to see some signals that they have increased number of myocardial infarctions in our study. So whether statins affect those, and what are the risk factors for disease in women? Also, we're very proud that only 35% of the population is white. It's a really, really diverse population, a global population. You can see the median age is 50. So these are patients that you might have in your clinic that you wouldn't ordinarily be thinking of cardiovascular prevention on. In terms of their HIV history, the median duration of disease is 13 years. The CD4 count is robust at 621. The vast majority have undetectable viral load. The assays differed across continents and GBD regions, but about only 10% had a viral load that was above the largest assay limit. And ARV use was 9.6 years. What have we learned from REPRIEVE thus far? Well, we started to publish a significant number of papers, and I'm just going to take the last few minutes of this to go over some of the highlights of what we've learned so far. So one of the key publications was in JAMA Network Open recently. This was the baseline of the sub-study. 755 participants, mean age 51. 48% of this group had subclinical coronary plaque, which is pretty astounding, including 30% who had ASCVD risk less than 5%, people you'd never expect to have plaque. 23% had vulnerable plaque features. And importantly, IL-6, oxidized LDL, and LP-PLA2 were significantly and independently associated with plaque, controlling for traditional risk factors, suggesting these particular pathways and maybe the inflammasome as well are significantly related. Recently, we had the opportunity to compare our cohort to a giant European cohort called SCAPIS, which is Northern European, but is a primary prevention cohort. And we also compared our cohort to the PROMISE cohort. These are patients with known chest pain, with known cardiovascular disease. So we stratified the patients based on age and looked at the percentage of with any atherosclerotic disease based on the same coronary angiography among all three groups was identical. And you can see that the REPRIEVE population had significantly higher disease than SCAPIS and almost the same as PROMISE at equivalent ages. So it's quite incredible. When they looked at non-calcified plaque, particularly in that category, REPRIEVE participants had the highest percent of patients with non-calcified plaque. And this was true at various different stratifications of ASCVD. Also another interesting observation. We've had the opportunity to look at unique protein pathways using high-level proteomics. And we related different proteins using O-link platform to vulnerable plaque. And we've learned a few things. One of them is that a completely novel protein jumped out at us, neuropilin-1. NRP1 has a role in T cell signaling and angiogenesis through VEGF-R1. and there's increased expression of NRP1 on T cells, and this may increase the migration of inflammatory T cells to plaque and increase interferon secretion in patients with HIV, and it had by far the highest odds ratio relating to vulnerable plaque, and this is ASCVD adjusted. We published this in JID just recently. So again, REPRIEVE is showing us new pathways that we may consider to ameliorate cardiovascular disease in this population. Turning to sex for one moment, studies have highlighted sex differences in HIV attributable risk of MI. And this is the relative risk in men with and without HIV and women with and without HIV. And you can see that the relative risk is much higher in women with HIV than men. Overall, men have a higher risk than women, but the relative risk within sex is higher in women. Why is that? Why is that the case? Well, one thing we've learned is that females with HIV who experienced MI were more likely to present with type 2 MI, whereas males were more likely to present with type 1. As you may remember, type 1 is an MI caused by atherothrombosis in a coronary artery supplying the infarcted myocardium. That's the traditional MI. Type 2 is caused by a myocardial oxygen supply-demand mismatch without atherothrombosis, and it's becoming apparent that perhaps women have more type 2 MIs, and the reason for that we're trying to investigate. One interesting recent observation in REPRIEVE is that females had much higher levels of IL-6, CRP, and D-dimer, but lower levels of LP-PLA2, and these differences persisted after adjustment for ASCVD risk score, so it's possible that certain combinations of inflammatory pathways may contribute. We've also had the opportunity to look at other traditional risk factors in REPRIEVE. This was a global study of diet in our patients, and we used a standardized dietary format. I just want to make one point that I don't want to forget the traditional things, and here's diet, and the red bar and the blue bar are suboptimal or poor diet. And across the entire REPRIEVE population, 42% of patients had a suboptimal or poor diet. This was much more the case in high-income regions, but also and much less the case in Asian regions. But also in sub-Saharan Africa, it was a very, very high percentage of poor diet. So we're going to investigate that. And lastly, I'll just end with one more final vignette, and I know Dr. Soretti is going to talk more about this. But CHIP, these are clonal expansions of stem cells, and they relate to leukemogenic mutations. And these mutations are not significant enough to cause cancer. But interestingly, CHIP is associated with twofold higher cardiovascular disease risk, and it's very significant. It may be a very significant driver of inflammation. So we took the opportunity to genotype the entire REPRIEVE population, and those data are forthcoming. But I'll just give you a snippet of what we know so far. And here are data to suggest, and these are going to be presented at CROI, that CHIP, the prevalence of CHIP goes up with age in everybody. It's a driver mutation that goes up with age. But it goes up more and is faster increase in patients with HIV than a non-HIV reference population. So that's interesting. Other groups have published on this, but to my knowledge, they have not published on the fact that the nadir CD4 is really strongly associated with CHIP mutations. And perhaps Dr. Soretti can comment on that later. But so there not only there are environmental, there are genetic, there are inflammatory, all sorts of pathways which uniquely contribute, and hopefully REPRIEVE will be able to answer these questions. So I'd like to conclude by saying that modulation of traditional and non-traditional risks is necessary to prevent cardiovascular disease and HIV. I think I showed you data on that. And that ART with viral suppression is great. Go for it. It's critical, but it's probably not enough to prevent cardiovascular disease. We need something else. REPRIEVE will inform us of the utility and safety of one particular strategy, a statin strategy, to prevent MACE and reduce coronary plaque in people with HIV. Anything you do in this population has to be generalizable, easy to use, risk-free, and statins just rise to the top, and that's why NIH funded this particular study. REPRIEVE will also inform us of the risk factors which predict MACE and plaque progression, suggesting other potential targets and strategies as well. And finally, I would like to thank our site PIs, as I said, many of which are in the room here, study teams, trial networks, funders, and participants. Thank you very much for your attention. Appreciate it.
To the table, and now we will follow